Friends, welcome to one more teaching session by Prof Q. Today we will use our AI to discuss a very specific topic essential for NEET PG as well as your clinical practice. So that is surgery topic. It's a surgery topic. The subtopic is trauma surgery. Trauma surgery carries a big weight in your NEET PG examination. It is very frequently asked. So without wasting time, let us go ahead and discuss a few MCQs that will help you crack your NEET PG. Okay, let's go to the first case. A 24-year-old man with blunt chest trauma is intubated for respiratory distress. Immediately after starting positive pressure ventilation, his blood pressure drops to 70/40. Right hemithorax is hyperresonant with absent breath sounds. Trachea is central. And what is the most appropriate next step? Okay, now this is how the AI will help you. Now with a BP of 70/40, it's life-threatening shock or hypotension. The right hemithorax hyperresonance is suggestive of air accumulation. Absent breath indicates lung collapse or air in the pleural space. Central trachea may not give you a good differential, but it is specifically mentioned because a shifting trachea is a late feature and is intubated patient. Okay, the primary problem, the diagnosis is that patient is experiencing a tension pneumothorax on the right side causing hypotension. So any hyporesonance, absent breath sounds in the presence of hypotension and respiratory distress indicates a tension pneumothorax. Now remember, the central trachea, which is not deviated, does not exclude a tension pneumothorax. Clinical compromise takes precedence. So the recommended initial management is insertion of a large bore needle into the second intercostal space in the mid-clavicular line on the affected side. Okay, so that is the main thing. So tension pneumothorax, the key thing to learn is that after positive pressure ventilation, it is a clinical diagnosis, requires immediate needle decompression without waiting for imaging. Now let us look at one more question. Okay. This is also a very commonly tested scenario. It's a 35-year-old woman is brought after a high-speed collision. Pulse is 132, tachycardia, BP is 76/48, and the GCS is 14. And abdomen is distended, minimally tender. After blood product resuscitation, BP remains 80/50. That's inadequate resuscitation. And fast demonstrates free intraperitoneal fluid. What is the next best step? Should you image more? Should you do some tests? Should you go for laparotomy, or you can repeat fast of fluids? Now look at the AI pulling up the key things. Key features are hypotension, tachycardia, a distended abdomen, and a moderate concern GCS. But the free intraperitoneal fluid on fast is seen. The primary problem is hemorrhagic shock due to an intra-abdominal bleeding. So the fast showing free fluid indicates there is intra-abdominal bleeding, and it's significant because of the presence of hemorrhagic shock, non-responsive to blood product resuscitation. So the next best step is urgent exploratory laparotomy to control bleeding and manage. So positive fast with hypotension and trauma mandates urgent laparotomy. So that is the key learning point. And early surgical control of bleeding improves survival in hemorrhagic shock. Okay, that is a very, very key question. Let us look at one more question. Apologies for the phone call. I frequently get called from the hospital. Let's look at one more MCQ. A 42-year-old man is crushed between two vehicles. He is hypotensive, but fast is negative. The pelvis is unstable and right leg is externally rotated. Massive transfusion has been activated. What should be performed immediately? So either we can do CT angiogram, skeletal traction placement, internal fixation, or a pelvic binder application. So let's see how the AI looks at it. It picks up all the clinically relevant information. It's an unstable pelvic fracture with hypotension, but the fast is negative. So there's a massive bleeding protocol involved. So the pelvis is one of the most common sites of bleeding in the presence of hypotension and a negative fast. So the priority is mechanical stabilization. We cannot do anything immediately. So the mechanical stabilization of an unstable pelvis is done by applying a pelvic binder or a sheet at the level of the greater trochanterus. And then if during exploration, we also can do preperitoneal pelvic packing. Angioembolization is all done much later. So your learning point, unstable pelvic fractures with hypotension and negative fast, apply a pelvic binder to immediately control bleeding. This precedes other interventions like packing or angioembolization in a pelvic hemorrhage patient. Let us look at one more question. This question is very, very important from the point of your entrance examination. Across board, this is very, very commonly asked. So this one is about a chest injury. A 29-year-old man sustains a stab injury to the left chest. A chest tube immediately drains about 1700 ml of blood. Despite transfusion, he remains tachycardic and hypotensive, and we have to find out the next definitive step. Now, yes, it's a stab injury to the left chest, a life-threatening trauma, an immediate chest tube drainage of 1500 ml, 700 ml blood, which is a massive pneumothorax and is of urgent concern. Okay, so the primary problem is a massive ongoing intrathoracic bleeding causing hemodynamic instability. So trauma management principle says that when you have a chest trauma with a massive hemothorax, when the initial output, chest tube output, is more than 1500 ml, or an ongoing bleeding more than 200 ml for the continuous 3 hours, mandates surgical exploration via a thoracotomy. Okay, so initial chest output more than 1500 ml needs urgent thoracotomy for bleeding control. That is the key lesson. Okay, let us look at one more question now. This is a little tricky question. A 22-year-old man has a severe traumatic brain injury and an intra-abdominal bleeding. GCS is low, 6, BP is low, hypotensive, and fast is positive. Now somebody is suggesting permissive hypotension while surgery is being arranged, and the question is which systolic blood pressure target is most appropriate. This tests a very important principle in the practice of permissive hypotension in surgery. So let's see how the AI looks at it. Whatever we have discussed so far, the patient has severe traumatic brain injury with hypotension and intra-abdominal bleeding causing hemodynamic instability. So the key point is, in a traumatic brain injury, hypotension is associated with worse outcome. Permissive hypotension is contraindicated in the presence of traumatic brain injury. So your target systolic pressure should be more than 100. Okay, so ideally a blood pressure of more than 110 millimeters of mercury is required in the presence of traumatic brain injury. So that is the right answer. You have to maintain SBP more than 100 in young adults with severe traumatic brain injury to improve outcomes. Ideally it should be more than 110. Let us do one more question on trauma. Now here is the question. A 31-year-old male sustains a blunt abdominal trauma. BP is 116/72, which is stable without vasopressors. That is very good. But CT shows an AAST grade 4 splenic injury with active contrast extravasation. There is no peritonitis. What will be the best management? Will you observe him? Will you do immediate splenectomy? Will you do splenic artery embolization? Or you will repeat CT after 24 hours? So let's see how it pulls up. Trauma type is blunt abdominal trauma. Splenic grade is AAST grade 4. Imaging findings, active contrast extravasation on CT, which means CT is essentially showing bleeding. Hemodynamic status is stable, and abdominal examination, no peritonitis. So now, do you do non-operative management or an operative management? Definitely hemodynamically stable, AAST grade for splenic injury, and active contrast extravasation and peritonitis. These are the findings, and management depends on hemodynamic status and not on the grading of splenic injury. Stable patients should be managed non-operatively. Active contrast extravasation means there is active bleeding, but as long as the patient is stable, you don't need an open surgery. So the best thing is using an interventional radiology by angiographic embolization. So that is the key point in this MCQ. We can see one more question now. A 36-year-old with pelvic fracture has blood at the urethral meatus, perineal ecchymosis, and inability to void. Bladder is palpable, his hemodynamics are stable. And what investigation should you do before putting a Foley in? Urinary catheterization. Will you do an pyelography, retrograde urethrophy? Will you do flexible cystoscopy, or you will do ultrasound of the bladder? So the AI picks up the key one. So in a male patient with a pelvic fracture and blood at the urethral meatus, there is a strong suspicion of urethral injury. So blind urethral catheterization is contraindicated in the presence of urethral injury. So you have to do, before catheterization, a retrograde urethrogram with water-soluble contrast. Okay? So this is the investigation of choice. So good. We have revised some questions. I also always wanted to keep this lesson short. I will encourage you to try more and more questions on Prof Q's discussion room, which is our AI-based agent in Cubase. Cubase is our baby and is created by medical teachers to help students achieve good marks in NEET PG and NEET examinations. It has a very unique platform, not time bound. It also has got examinations on NEET as well as NEET, and this is the only interactive AI which will provide teacher-like quality tutorials at any time of the day to discuss all your doubts in both MBBS times as well as during NEET PG preparations. So the link is given in the description of this video. If you like this video, like it, please subscribe to our channel and also share it with your friends so that more and more people can benefit from the discussion. Thank you very much. We will meet very shortly with another set of questions. Thank you.